Welcome to the deep dive. Today, we're tackling a really significant health challenge, heart failure.
Yeah, a big one.
We've got a great source to explore, Chapter 44, from a nursing pharmacology textbook, actually.
Mm-hmm.
And our mission, really, is to get a solid grasp of, what happens when the heart muscle struggles, how that shows up, and crucially, the medications used to manage it.
Exactly. It affects so many people. And while it sounds complex and it is understanding the basics, the mechanisms, and the treatments is, well, it's really empowering.
Yeah, definitely. So let's dig in.
Let's do it. Get to the heart of it, you could say.
Okay, so at its core, heart failure just means the heart muscle isn't pumping blood effectively, right?
Yeah.
Not enough to meet the body's needs.
That's the essence of it. And this leads to a kind of backup of blood, which we call congestion.
Right, congestion. And a key idea here is cardiac output. The book reminds us that's heart rate multiplied by stroke volume, how much blood gets squeezed out with each beat.
And in heart failure, that output is often, well, pretty low, lower than it should be.
So what happens then?
Well, that reduced output causes problems. If it's the left side of the heart that's weak, blood backs up into the lungs, pulmonary congestion.
Okay.
If it's the right side having trouble, the backup happens in the rest of the body circulation, the systemic circulation.
And the basic issue in both cases?
Fundamentally, our cells just aren't getting enough oxygen and nutrients, and the waste products aren't getting cleared away properly.
Got it. The textbook also lays out these stages, the ACCHA stages, A through D, to track progression. Stage A.
Stage A is basically high risk. You might have conditions like hypertension or diabetes, but no actual structural damage to the heart yet, and no symptoms either. It's like a warning sign.
An alert stage?
Yeah.
Okay. Then stage B.
Stage B, you actually have some structural heart disease. Maybe the heart's enlarged or there's a valve problem. But, and this is key, still no signs or symptoms. The problem's there, but it's not causing trouble yet.
Okay. The engine has a fault, but it's running okay for now.
Kind of, yeah. Then stage C is where you have that structural disease and you've had symptoms either now or in the past.
Like shortness of breath, fatigue.
Exactly. Things you notice.
And stage D?
That's the advanced stage. Refractory heart failure. Symptoms are there even with maximum medical treatment, and you might need more specialized things like transplants or mechanical pumps.
Wow. Okay. And alongside these stages, there are the NYHA functional classes, class 1 to 4 vert.
Right. These focus more on how symptoms limit your physical activity. Class I, basically no limitations. Ordinary activity doesn't cause problems.
Pretty much normal function.
Yeah. Class 2, there's a slight limitation. You're okay at rest, but normal activity brings on symptoms, fatigue, shortness of breath, that kind of thing.
You start to notice it.
Class 3, the limitation is more marked. You're still okay resting, but even less than ordinary activity causes symptoms.
Okay.
And Class 4 is the most severe. Symptoms can happen even at rest, and any activity makes it worse.
So the stages tell you about the disease progression, and the classes tell you about the day-to-day impact.
Precisely. They give a really comprehensive picture together.
The book also distinguishes between systolic and diastolic dysfunction. Can you unpack that?
Sure. Systolic dysfunction is often called HFrEF, heart failure, with reduced ejection fraction. The left ventricle, the main pump, just isn't squeezing forcefully enough.
And ejection fraction is that percentage of blood pumped out.
Right. Normally it's maybe 55, 70%. In HFrEF, it's 40% or less.
Okay. And diastolic.
Diastolic dysfunction is different. The ejection fraction might look normal, but the problem is the heart muscle can't relax properly between beats. It's stiff, so it doesn't fill up with blood efficiently.
Ah, okay. So filling problem versus pumping problem.
Kind of, yeah. And it's actually possible to have a mix of both systolic and diastolic issues going on.
Right. Now, zooming in even more, the book mentions the cellular level, the sarcomere.
Yeah, the sarcomere. That's like the fundamental engine unit within each heart muscle cell. It has proteins, actin, and myosin.
They slide past each other for contractions.
Exactly. And that's regulated by other things like troponin and, really importantly, calcium.
Calcium's the trigger.
Sort of the key that unlocks the contraction machinery. And for this whole process to work, these little engines need fuel, oxygen, glucose, and that calcium.
So if anything disrupts that fuel supply or the machinery,
it can contribute to heart failure at a really basic level.
Yeah. So what are the big picture causes then? What leads to this? The book lists a few main ones: coronary artery disease, CAD.
Yeah, CAD is a big one. If the arteries supplying the heart get narrowed, the heart muscle doesn't get enough oxygen, that's hypoxia. It can damage the muscle or even lead to a heart attack, an MI, which kills off heart tissue.
Okay, makes sense. What else?
Cardiomyopathy. That's basically a disease of the heart muscle itself, making it weak.
What causes that?
Oh, various things. Viral infections, drinking too much alcohol. Sometimes it's genetic. Lots of causes. The result is the heart can't contract well and often gets bigger cardiomegaly.
Enlarged heart. Okay. Hypertension, high blood pressure.
Definitely. If your blood pressure is consistently high, the heart has to pump against much more resistance. It's like lifting heavier weights all the time.
So it gets overworked.
Exactly. Over time, the muscle thickens and enlarges to cope, but that enlarged muscle actually needs more oxygen, which can become a problem.
And the last one mentioned is valvular heart disease.
Right. If the heart valves, the doors that control blood flow, are leaky or too narrow, it messes up the flow.
Creates extra work for the heart.
Yep. The heart has to work harder to push blood through a narrow valve or compensate for blood leaking backward. This stretches the heart chambers and increases the workload again.
Okay, so several major pathways leading to this weakened pump. Now, let's talk specifics. Left-sided heart failure. What happens there?
So, if the left ventricle, the main pump pushing blood out to the body, is failing, blood starts to back up. And where does it back up from?
The lungs.
So it gets congested back into the lungs, like a traffic jam.
Exactly. Pulmonary congestion.
Yeah.
And that leads to symptoms.
Rapid, shallow breathing tachypnea. That awful feeling of breathlessness, dyspnea, which can cause anxiety too, and orthopnea, difficulty breathing when you lie flat. People often say how many pillows they need to sleep propped up.
That's a classic sign.
It is. Also coughing, sometimes with blood-tinged sputum, that's called hemoptysis. And doctors might hear crackling sounds in the lungs called rales.
Sounds like fluid.
It is. And in really severe cases, it can progress to pulmonary edema where fluid floods the air sacs. That's a medical emergency.
Definitely sounds serious. Okay, so that's the left side backing up into the lungs. What about right-sided heart failure?
Well, often right-sided failure actually happens because of left-sided failure. If the left side is struggling, it eventually puts strain on the right side.
Makes sense.
Or it can be caused by lung diseases that increase the pressure in the lung arteries, pulmonary hypertension. That directly increases the workload on the right ventricle.
So what does it look like when the right side fails? Where does the backup go?
Instead of the lungs, the backup is in the body's main venous system, the veins returning blood to the heart.
So what signs do you see?
You might see the jugular veins in the neck bulging, that's elevated JVP. The liver can get enlarged and tender, that's hepatomegaly. Sometimes the spleen too, splenomegaly.
Okay.
People might get GI issues like nausea or pain because of fluid congestion in the abdomen. And a really common one is peripheral edema, swelling in the legs, ankles, feet, any place gravity pulls fluid down.
The swollen ankles people talk about.
Often, yeah. You might also find weaker pulses in the arms and legs, maybe some hypoxia, and interestingly, nocturia.
Having to pee a lot at night. Why is that?
When you lie down, some of that fluid that's been pooling in your legs during the day gets reabsorbed into the circulation, goes to the kidneys, and you make more urine. It's all connected.
It really is. And the book emphasizes that if one side fails and isn't treated,
it can eventually lead to failure of the whole heart, total heart failure.
Okay. But the body doesn't just give up, right? It tries to compensate.
Absolutely. The body has these built-in compensatory mechanisms that kick in when things aren't right. The textbook explains these well.
So when cardiac output drops, the body notices.
Yeah. Special sensors, called baroreceptors in the big arteries, detect the lower pressure. They send signals to the brain, which activates the sympathetic nervous system.
A fight or flight system.
That's the one. It does a few things. Increases heart rate, trying to pump more often. Increases blood pressure to keep circulation going, makes you breathe faster and deeper.
Okay.
It also has a positive inotropic effect, makes the heart muscle contract a bit stronger. And it tells the body to hang on to salt and water by releasing aldosterone, which increases blood volume.
So trying to boost output and keep pressure up.
Basically, yeah. Plus, that reduced blood flow to the kidneys triggers another system, the renin-angiotensin-aldosterone system, or RAAS.
Ah, yes, RAAS. What does that do again?
It further constricts blood vessels and makes the body retain even more sodium and water. So more increased blood pressure, more increased volume.
It sounds helpful initially.
It is, in the short term. It helps maintain blood pressure and flow. But here's the catch.
There's always a catch.
Pretty much.
Yeah.
Long term, all these compensatory things, the faster heart rate, higher pressure, extra fluid, stronger squeeze, they actually put more strain on the already weakened heart.
Oh, right. So they end up making things worse over time.
Exactly. They contribute to that heart muscle enlargement, the hypertrophy we mentioned, make the heart need even more oxygen, and can actually decrease blood flow to the heart muscle itself eventually. Yeah, it's a vicious cycle, really.
A double-edged sword. Okay. So how does this all look when a patient actually presents? How do doctors figure it out?
Well, the clinical picture is usually pretty predictable, reflecting both the heart's pumping issues and those compensatory effects.
And for diagnosis?
Several key tools. A chest x-ray, radiography can show if the heart's enlarged or if there's fluid in the lungs. An ECG, electrocardiogram, can pick up signs of that heart muscle thickening or common rhythm problems like atrial fibrillation or flutter.
AFib is common in heart failure.
Very common, yeah. And then there's the echocardiogram, the echo.
The ultrasound of the heart.
Right. That gives really good information about the heart size, the wall thickness, how well the valves are working, and crucially, that ejection fraction we talked about.
Okay. The book also mentions anxiety, which makes sense, and heart murmurs.
Yeah, anxiety is common with breathlessness, and murmurs can point towards those underlying valve problems being a cause or contributor.
Right. So now, the crucial part, treatment. Guideline-directed medical therapy, GDMT. What's the goal here?
The main goal, as the book lays out, is really to slow down or ideally reverse the progression of heart failure. We do that by reducing the heart's workload and managing the fluid overload.
Makes sense. So what are the key medications? The textbook lists quite a few.
Yeah, there are several core classes. First up, drugs that block that RAS system. This includes ACE inhibitors, ARBs, angiotensin receptor blockers, and the newer class, ARNAs, angiotensin receptor neprilysin inhibitors.
RNI, like Entresto.
Exactly. Sacubitril valsartan. That's often preferred now if possible. They all work to relax blood vessels and reduce fluid retention by blocking RAAS.
Okay. Then beta blockers.
Yes, essential. Drugs like bisoprolol, carvedilol, metoprolol, succinate. They block the effects of that overactive sympathetic nervous system.
Slow the heart rate down, reduce the workload.
Precisely. Take some strain off the heart.
What else? Aldosterone antagonists?
Like spironolactone or eplerenone. These are usually added for most patients as long as their kidneys are working okay and their potassium levels aren't high. They give an extra block on aldosterone, helping with fluid and potentially remodeling of the heart.
And diuretics, of course.
Absolutely. Loop diuretics like furosemide are key for managing fluid overload symptoms. They help get rid of excess salt and water, reducing congestion, reducing preload and afterload, basically easing the heart's job.
Now, the book mentions SGLT2 inhibitors. Weren't those diabetes drugs?
They were originally, yeah, like dapagliflozin and empagliflozin. But they've shown really impressive benefits in heart failure, even in people without diabetes. They reduce cardiovascular death and hospitalizations.
Wow, that's interesting. How do they work in heart failure?
The exact mechanisms are still being fully understood, but it seems to involve effects on fluid balance, blood pressure, metabolism, and maybe even directly on the heart muscle. But the bottom line is, they work.
Okay. What about hydralazine and isosorbitunitrate, Bedil?
Right. That combination seems particularly beneficial for Black patients who still have symptoms despite being on the other standard therapies. The textbook suggests it might relate to differences in endothelial function, how their blood vessels work.
Interesting. And Ivabradine?
Ivabradine is used in a specific situation. Stable patients already on max beta blockers, or can't take them, still in normal rhythm, but with a heart rate of 70 or more, and NYHA class 2 or 3. It slows the heart rate via a different mechanism than beta blockers.
Okay, lots of options tailored to the patient. What about when things go wrong suddenly? Acute decompensation.
Yeah, if someone's heart failure suddenly gets much worse, maybe their blood pressure drops really low, or their kidneys take a hit, sometimes these GDMT meds actually need to be stopped or reduced temporarily.
And the focus shifts.
The immediate focus shifts to stabilizing them, often trying to improve cardiac output directly, maybe with IV medications.
Got it. The book also briefly mentions beta-adrenergic agonists.
Yeah, those can increase calcium in the heart cells for a stronger contraction, a positive inotropic effect. But they also have other sympathetic effects that can sometimes worsen heart failure long-term, so they're used cautiously, usually in acute settings.
Okay. Now let's dive deeper into some specific drug classes. Cardiotonic agents, or inotropes, what's their main job?
Their main job is to increase the force of the heart muscle contraction. They directly make the heart squeeze harder.
How?
Usually by increasing the amount of calcium available inside the heart muscle cells during contraction. More calcium, stronger squeeze.
And the result of that stronger squeeze?
Increased cardiac output. More blood gets pumped out. This improves blood flow everywhere, including the kidneys.
Ah, so better kidney flow means...
It can act like a diuretic, helping get rid of fluid. And better kidney flow also tends to decrease renin release, which helps dial down that problematic RAS activation.
Okay, and the book mentions two main types.
Yes, the older cardiac glycosides, mainly digoxin, and the phosphodiesterase inhibitors like Milrinone.
Let's start with digoxin then, lanoxin. Comes from the foxglove plant.
That's right, digitalis. It's been used for centuries, actually.
So what exactly does digoxin do?
Well, as we said, it increases intracellular calcium, giving that stronger contraction-positive entropy. It boosts cardiac output and renal perfusion, giving that diuretic effect. But it also slows the heart rate down.
Negative chronotropy.
Exactly. And it slows down electrical signals through the AV node, which is why it's used for some arrhythmias too, like atrial fibrillation.
So stronger pump, slower rate, better output. Sounds good for heart failure.
It can be, yeah. It's indicated for heart failure and certain arrhythmias like AFib, atrial flutter.
But the book stresses it has a narrow therapeutic index. What does that mean?
It means the dose needed for it to work is very close to the dose that causes toxicity. There isn't much margin for error.
Ah, okay. Like walking a tightrope?
That's a good analogy. Requires really careful dosing and monitoring of blood levels.
How does the body handle it? Pharmacokinetics?
It comes as pills or IV, absorbed pretty well orally, gets distributed widely. And here's a key point. It's mostly excreted, unchanged by the kidneys.
So kidney problems are a big deal with digoxin?
A very big deal. Dose usually needs to be reduced significantly if kidney function is poor.
And when should it definitely not be used? Contraindications?
Allergy, obviously. Certain dangerous heart rhythms like VTach or VFib, some types of heart block or sixth sinus syndrome, a specific heart muscle condition called IHSS, acute MI, severe kidney issues, and electrolyte problems, especially high calcium, low potassium, or low magnesium.
Why low potassium?
Low potassium actually makes the heart more sensitive to digoxin, increasing the risk of toxicity. It's a really important interaction to watch for, especially if patients are also on diuretics that waste potassium.
Got it. And caution in pregnancy.
Yes, caution in pregnancy and lactation.
What about side effects?
Can cause headache, weakness, drowsiness. Classically, visual changes, patients might see yellow or green halos around lights.
Yellow halos. Wow.
Yeah, it's quite specific.
Yeah.
Also, GI upset, nausea, loss of appetite are common early signs of trouble. And importantly, it can cause various heart rhythm problems itself.
So digoxin toxicity is a real risk. What does that look like?
Often starts with that loss of appetite, nausea, vomiting, just feeling generally unwell, maybe depressed, and then you can get all sorts of irregular heart rhythms, some very dangerous.
Is there an antidote?
Yes, thankfully. There's digoxin immune fab or digifab. It binds to the digoxin in the blood and neutralizes it.
That's good to know. And lots of drug interactions mentioned.
Oh, loads. Some drugs like verapamil or amiodarone can increase digoxin levels. Others might decrease its effect. Things like antacids or cholestyramine can reduce its absorption.
And potassium-losing diuretics increase the arrhythmia risk.
Exactly. It's a drug that requires a lot of vigilance regarding interactions. Even herbal ones, St. John's wort, can decrease levels, while things like ginseng or licorice might increase toxicity risk.
Licorice?
Yeah, black licorice can mimic aldosterone and cause potassium loss, which, as we said, is bad with digoxin.
Huh. The case study in the book about the patient whose levels dropped after eating bran cereal really highlights the absorption issue, doesn't it?
It really does. Taking it consistently away from high-fiber meals or certain supplements is important.
Okay, let's shift to the other type of inotrope. Phosphodiesterase inhibitors. Milrinone, how does that work?
Milrinone blocks an enzyme, phosphodiesterase. Blocking this enzyme leads to more CAMP, a signaling molecule inside the cell.
And more CAMP means?
More calcium influx, similar endpoint to digoxin in a way, leading to a stronger contraction. It also tends to prolong sympathetic effects.
Does that have downsides?
It can. That prolonged sympathetic stimulation can cause vasodilation, which might drop blood pressure too much. It increases the heart's oxygen demand, and there's a significant risk of arrhythmias.
So when is Milrinone used?
Because of those risks, especially arrhythmias, it's really reserved for short-term treatment of severe heart failure, typically in the hospital setting, when other drugs like digoxin and diuretics aren't cutting it.
Not a long-term solution.
Generally not. Usually for acute situations like a bridge to recovery or other therapies.
How's it given?
5E infusion only. It gets metabolized by the liver and excreted by the kidneys.
Contraindications.
Allergy, severe aortic or pulmonic valve disease. It won't help if the valve is the main problem.
Sure.
Acute MI, dehydration, and existing ventricular arrhythmias. Use with caution in older adults, pregnancy, lactation.
And adverse effects.
The big one is ventricular arrhythmias, which can be fatal. Also hypotension, chest pain, GI upset, low platelets, thrombocytopenia, and hypersensitivity. Oh, and it can burn at the IV site.
And don't mix it with furosemide in the IV line.
Right. They precipitate, form solids if mixed directly.
Okay, now for a newer class. HCN channel blockers. Ivabradine, Corlinor. How does this one work differently?
This is interesting. Ivabradine works directly on the heart's natural pacemaker, the sinus node. It selectively blocks these funny channels, the HCN channels.
Funny channels.
Yeah, that's what they're sometimes called. Blocking them slows down the firing rate of the sinus node.
So it just slows the heart rate. It doesn't affect the squeeze, the contractility.
Exactly.
Yeah.
Unlike beta blockers, it doesn't directly affect contractility or blood pressure much. The main effect is reducing the heart rate.
And the idea is that a slower rate allows more filling time.
Right, more time for the ventricles to fill between beats, which can improve stroke volume and overall cardiac output in some patients.
Any downsides compared to beta blockers? Or upsides?
Well, it doesn't have the same potential side effects as beta blockers like fatigue or bronchospasm. But it can affect similar channels in the eye's retina.
Leading to?
Those visual disturbances, luminous phenomena, seeing flashes of light or brightness changes.
Okay, so who gets Ivabradine?
Specific criteria. Stable chronic heart failure patients with a reduced ejection fraction, like 35%, who are in normal sinus rhythm, have a resting heart rate of 70 or more. A and D are either on the maximum tolerated beta blocker dose or can't take beta blockers. The goal is reducing hospitalization risk.
Quite specific. Also used in kids with dilated cardiomyopathy.
Yes, that's another indication.
How's it handled by the body?
Taken orally, absorbed quickly. Metabolized by the liver and intestines, mainly via the CYP3A4 enzyme system that's important for interactions. Excreted mostly in feces. Fairly short half-life, about 2 hours.
Contraindications.
Allergy, active decompensated heart failure, very low blood pressure or heart rate, below 60, sick sinus syndrome or AV block, unless they have a pacemaker, severe liver problems, and taking strong CYP3A4 inhibitors, which would boost Ivabradine levels.
And caution with AFib or moderate heart block?
Yes, and pregnancy breastfeeding.
Main side effects again?
Bradycardia, slow heart rate, sometimes hypertension, atrial fibrillation can occur, and those visual phenomena.
And drug interactions. Watch out for CYP3A4 inhibitors and inducers?
Definitely. Inhibitors increase levels, inducers decrease them, and combining it with other drugs that slow the heart rate, like beta blockers or certain calcium channel blockers, increases the risk of severe bradycardia.
Okay, one more major class to cover. ARNIs. Angiotensin receptor necrolysin inhibitors. Sacubitril valsartan? Entresto?
Right, another relatively newer combination drug approved around 2015 really made a splash.
What's the big deal?
It's shown to be better than ACE inhibitors or ARBs alone at reducing hospitalization and cardiovascular death in chronic HFrEF. It's now a foundational therapy, often preferred first line if tolerated and affordable. Also used in some pediatric heart failure cases.
So how does this combo work? It's got two parts, sacubitril and valsartan.
Exactly. Valsartan is an ARB. We know those blocks angiotensin II, blocks the bad effects of RAS. Sacubitril is the new part. It inhibits an enzyme called neprilysin.
Neprilysin, what does that do?
Neprilysin normally breaks down beneficial substances in our body called natriuretic peptides.
Natriuretic peptides, they sound good.
They are. They help us excrete sodium in water, relax blood vessels, and reduce pressure. Good things in heart failure. So, by inhibiting neprilysin, sacubitril lets these helpful peptides stick around longer and do their good work.
So you get the RAAS blockade from valsartan plus the boost in beneficial peptides from sacubitril?
Precisely. It's a dual mechanism, a synergistic effect. Reduces workload, lowers volume and pressure, improves symptoms.
Makes sense why it's often preferred. How's it handled?
Oral pill. The drug splits into sacubitril and valsartan. Quick peak levels, reaches steady state in about 3 days. Can take with or without food. Highly protein bound. Metabolized partly in the liver, eliminated in urine and feces. Half-life around 10 hours.
Contraindications seem important here, especially regarding ACE inhibitors.
Absolutely critical. You cannot use an ARNI concurrently with an ACE inhibitor, or even within 36 hours of stopping one. There's a high risk of angioedema, that's serious swelling.
So a washout period is needed if switching.
Yes, a 36-hour washout period after stopping an ACE inhibitor before starting Entresto. Other contraindications include a history of angioedema with any ACE or ARB allergy, using it with aliskiren in kidney patients, and definitely pregnancy and breastfeeding, big risk of fetal harm.
Side effects.
Common ones are hypotension, low blood pressure, hyperkalemia, high potassium, cough, dizziness, and potential for worsening kidney function. Angioedema is less common, but serious when it happens.
So monitoring blood pressure, potassium, and kidney function is key.
Essential. Regular checks are needed.
And drug interactions, besides the ACE inhibitor issue.
Caution with aliskiren, increased hyperkalemia risk with potassium-sparing diuretics or potassium supplements, potential for lithium toxicity, and increased risk of kidney damage if combined with other nephrotoxic drugs like NSAIDs.
Okay, wow. That's a lot of ground we've covered on these medications.
It really is. So wrapping things up, heart failure is clearly complex, lots of causes. The body tries to compensate, but that often backfires.
Yeah.
And the treatment, this guideline-directed medical therapy, it's multifaceted. Reducing workload, managing fluid, using these different drug classes like the inotropes, HCN blockers, and especially the ARNIs and the other RAS blockers and beta blockers.
Each with its own way of helping, but also its own risks and things to watch out for.
Absolutely. It's about finding the right combination and dose for each patient.
Well, hopefully this deep dive gives our listeners a much clearer picture of, the nuts and bolts of heart failure and how these drugs fit in. It really shows how far treatment has come.
Definitely. And thinking about this whole intricate system, the heart, the circulation, how it tries to adapt, it's pretty amazing, isn't it? Both how resilient it can be, but also how things can go wrong.
It makes you wonder, given everything we've discussed, all the different ways the heart's function can be affected and treated, what other questions pop up? What further complexities are there in keeping this vital organ healthy?
That's a great thought to end on. Hopefully this provides a solid foundation for anyone wanting to explore cardiac health even further.